Smoking related ILDs. In smoking related ILDs, a lot of spectrum of diseases are there, but we are going to focus today on RB and RB-ILD. RB is respiratory bronchiolitis. Respiratory bronchiolitis, the key feature in the respiratory bronchiolitis is accumulation of bronchiolar pigmented macrophages. In cigarette smokers. And what is RB-ILD? It is the presence of changes of respiratory bronchiolitis as a sole pathological finding in current or former smokers with clinical evidence of ILD. So above plus clinical evidence of ILD, either radiologically or histopathologically. So what are the risk factors behind that? The risk factors are cigarette smoking. It could be current cigarette smoker or former cigarette smoker, usually more than 35 packs per year history. Now comes to pathogenesis. So the exact pathogenesis of RB or RB-ILD is not known, but since there is improvement in disease post cigarette cessation, so consideration are that it is smoking related. Plus radiological findings of small irregular opacities, which is also known as dirty lung, associated with it. Now comes to the clinical features. So the most important clinical findings in RB-ILD are dyspnea, present in more than 96% of the patients, wheeze, cough, sputum production. Then there are fine bibasilar and inspiratory crackles. They are common. Now how we are going to diagnose? So for diagnosis, we have certain tests like pulmonary function test. In pulmonary function test, the most common finding are mix, restrictive plus obstructive, reduced DLCO, occasionally isolated reduced residual volume would be there. Second is radiology. In radiology, we have X-ray and we have HRCT. In X-ray, we can appreciate diffuse, fine, reticular or nodular opacities, bronchial wall thickening, and some peribronchovascular marking plus prominent peribronchovascular markings. Let's come to HRCT. So in HRCT, the most commonest findings are bronchial wall thickening, then centribronchial nodules, then ground glass opacifications, air trapping, emphysema, other tests are Bell. So usually we don't do Bell, but the main point of doing Bell is to differentiate it with other differentials, and in the Bell we can see 10 pigmented macrophages, in the lumen of first plus secondary order of respiratory bronchioles, then transbronchial biopsy or surgical lung biopsy. In the biopsy we can similarly find 10 pigmented macrophages, some chronic inflammatory cells, histiocytes, lymphocytes, we can find them. How to diagnose it? So for definitive criteria, histo-radiological confirmation plus exclusion of other interstitial pneumonias. As we discussed above, what are the findings in histology, what are the findings in radiology. Plus exclusion of others. But it could be suspected and sufficient diagnosis can be made if there is history of smoking, current or former smoker with more than 30 or 35 packs per year, examination, crackles, PFTs with restrictive or mixed obstructive restrictive pattern, decreased DLCO, patient is having desaturation on ambulation, and most important, improvement with the smoking cessation. Now comes to treatment. Number one and foremost is smoking cessation. Most of the patients improved by this. Then you have supportive care. In supportive care, we have supplemental oxygen if patient is requiring it. We have pulmonary rehabilitation, influenza and pneumococcal vaccination. If despite of all patient is not improving, it's not being confirmed, but there are certain trials for steroids. You can start with 0.5 milligrams per kg per day, maximum of 30 milligrams, then followed by 20 and tapering it over quite a period of time. And rarely immunosuppressive therapy has been tried, but it's on trial basis. And if still patient is progressing towards severe respiratory failure, we can send patient for lung transplantation with the similar criteria as the other ILDs have. DLC of less than 39, oxygen saturation of less than 88% on 6-minute walk test, or FVC is declining more than 10% within 6 months. Survival. It has a prolonged survival, and usually patient responds by smoking cessation. Thank you. If you have any questions, you can comment down below.